Well, thank you, Dr. Westersund. That was an excellent talk. I will start the questions in the order that they've been presented. Do you have any pictures, Dr. Westersund, of daytime orthotics? Do you have any pictures, I guess, of them outside the mouth? That would appear to be the question.
Here's one.
He just took it out of his mouth.
Sorry to gross you out. I know this may be dinner time for somebody, but I've been wearing orthotic for about 20 years. I had severe migraines. I was rebuilt into CR by a prosthodontist when I had just graduated dental school back in the days of, well, we don't have to say, do we? Back in 79.
I'm older than you.
1980. Yeah, it's a long time.
Yeah.
Long time. But anyway, back before many people on this talk were born. The problem was I had 4 in the floor extractions when I was a young kid. I had airway issues. I had ground down my front teeth. That's why they went and rebuilt them back up with gold and things like that. And I had a lifetime of migraines, which is kind of why I went down this journey. So that's why I wear an orthotic. You can talk with them. I take them out to eat, but some of my patients have to leave them in to eat because of the dysfunction that they have. So there's a bunch of different ways that it can be used.
Okay, thank you. Next question, what material is the daytime orthotic made of? And you've already answered this, and do you wear it while eating? So what's it made of, and is it used for eating?
So it's made out of acetyl resin. And acetyl resin is very durable. You know, when we make acrylic orthotics, they typically break on the posterior on the buckle. We see that all the time. Oh, my orthotic broke, and it's way at the very back. These don't. They're very, very durable. You can't really bend it or it'll snap right in the center, but you can wear both. If patients unfortunately do that, you can wear both pieces together. It's not an issue. Yeah, I can eat with it. I do eat with it occasionally. Might have something small, but typically I'll take it out to eat just because I don't have to then clean it right away. Some patients have to. Some patients, their jaw joint dysfunction is just too great. They've got to wear it all the time. Otherwise, they're in pain all the time.
Okay, thank you. How often do you have to remake the daytime orthotic?
Well, how often are your patients going to take care of it, not lose it, not break it? Typically, these things don't wear out for plus 5 years. I have some that have been out there much like 10 years. I typically tell the patient that we're going to replace it every 3 to 5. And if it lasts longer than that, then I'm a hero. I like being a hero.
Okay, and a follow-up question, and I'm interpreting it. Oh, it just moved. Do you ever rebuild the person's occlusion to that position of the orthotic that you just described? In other words, do you replace teeth with plastic?
Yes. So that's a very good question. So phase 1 is getting somebody stable. Phase 2 still may be the MRD. So they want to keep wearing the nighttime appliance, but during the day, they want something different. So there's basically 4 different options. They could have orthodontics, and they could, using a couple of different techniques I won't get into, but you can use elastics and orthodontics to over-erupt teeth to let them come into the place where the daytime orthotic's going to be. You could restore the teeth. You could rebuild the teeth, and given the bites not having to open too much, there's a process you could go through to restore the teeth. You could have them just wear the orthotic long term, like I do. You could supposedly, I guess, have surgery. I haven't had anybody do that, but I guess it's theoretical, Or you could wean yourself back so you're not using as much, because now you've got this mobility and you're able to wear the MRD and you don't need it, the appliance during the day. Typically, I don't see that last one. We've done combinations where we do their upper teeth, as we showed with that last patient. She's going to get her upper teeth done to match the orthotic.
Okay, thank you. Can you correct the TMJ problem with a lower orthotic alone, or do you need to have an upper, perhaps in just a few cases? So can you do it with just a lower, or in some cases you need an upper as well?
Okay, so typically just a lower. Sometimes, though, that you don't have teeth on the top, and stability comes from all the teeth coming together. If you got to have, two teeth have to be coming together for there to be stability. You only have one tooth, it doesn't really function. So in the upper, we'll do, if we don't have upper teeth, maybe we'll make a partial denture. Maybe they'll get some implants and some crowns. They'll do something to give themselves a stable platform that the mandible can function against.
Okay. Are you speaking about a neuromuscular appliance here, doctor? Is this a neuromuscular appliance approach?
So obviously, everything that we do as patients has a neuromuscular component. I can't move my finger without there being a neuromuscular component. There's an afferent connection to the brain. The brain then tells the muscles what to do. So do I use a TENS machine, an ultra low frequency TENS machine? Yeah, you bet. And because I want to relax muscles, I want to allow the jaw to go to a happy position. Do I use equipment like a kinesiograph to tell me what muscles are doing, to measure muscle activity, look at what the jaw is doing? Yep, you bet. Is that the neuromuscular that certain places in southwestern United States was promoting? Kinda, but I mean, my goal is not to be doing full mouth reconstruction. My goal is to deal with chronic pain patients. And a lot of these chronic pain patients they have perfect teeth. They do not and should not have porcelain slapped onto all these teeth. That would be a sin in my consideration. They probably need some other type of treatment, whether it's orthodontic or whether it's something else that's helping restore those teeth.
Okay, thank you.
Can I just say I skirted around that issue because
yeah, we noticed that.
There's a lot of politics, David. There's a lot of politics.
Hey.
I mean, there's a lot of politics in your lovely province that says, oh, if you're doing neuromuscular, I have no idea what that means, but if you're doing it, it's bad. We have that same politics here in Alberta. And that's because there's been some operators that have pushed the limit a bit too far. But yeah, don't throw the baby out with the bathwater. You have to understand that there is I'm very much interested in the small n, small m of neuromuscular to release biomechanical stress and strain.
Right. You mentioned politics, and there's a co-partner called Ego and Politics. And if you ever want to know what it's like to be thrown under the bus, you and I should have a private chat sometime.
I think we could trade stories.
Yeah, I think we could. Anyway, this is all about our members. Next question. This is in two parts. There have been instances of bone formation in the condyle after long-term wear of orthotics. How about weaning? Does that make sense?
Yeah.
Long-term bone formation, long-term wear of orthotics is what it's about. Okay.
There's certain types of patients. I don't know if it's genetics or what, but there's certain types of patients that will grow bone. You know, when a ligament is injured, when you have a ligament in your neck that's injured, we often see ossification of that ligament. It repairs by calcifying. So long-term stress or strain on that ligament will repair by calcifying. We've all seen coronoid processes that are so long, and why did they grow that long? Well, there's a tendon that's attached to it, attached to a very big, strong muscle on the side of your head, and that temporalis muscle's elongating. We've all seen tori. We've all seen enlarged corner of the mandible in bone buttressing from antegonial notching. We've seen all these types of things. Is there that same change in the mandible? Not that I've seen. We probably could do a whole bunch of retrospective on patients with doing some more CBCTs, but I have not seen that in very many patients. Or can't tell you I've seen that other than in the literature.
Okay.
For those of you guys that are left, let me just clarify that I don't expect everybody to be doing the same type of treatment I'm doing. I do realize that running into a patient that has, you know, doc, I can't wear this, doc, I have a click, doc, now you've screwed me up, I can't bite. Dealing with those concerns ahead of time is always in your best interest. Doing some simple diagnosing is always in your best interest, but it's also your best interest. I mean, you guys all have, I'm not sure how many people use Matrix, David, or what type of sleep diagnostic machine they use, but you had to buy that stuff. Continue on with things that are going to really help your patient. Be aware of it so that patients that get treatment. I just before this lecture, I offer a free Zoom call to people that have TMD problems. And I was talking to a lady from Ontario, from Toronto. Yeah.
Oh my God. Oh.
She's got TMD problems. Where am I going to send her?
A place called London.
There wants to treat this?
Place called London.
And so, you know, that's who's able to sit there and deal with these. They're not really complex, but they're detailed changes for patients. So I hope everybody got something out of that. Maybe a little bit of a different perspective.
Dr. Lori Jones wants to ask an oral question. You have to open your mic, Lori.
Good evening, and thank you for your presentation.
Not a problem.
My question to you, it has to do with chronic concussion patients, injured in motor vehicle accidents primarily, who have a high symptom burden index, and the utilization of occlusion in daytime activity for these people is hard to get stabilization because they generally have a forward head posture, tight SCMs and traps and rolled shoulders and tender pectoralis muscles. And so,
yep, go ahead.
So these folk, the risk in starting to adjust either an orthotic or their natural teeth, they are potentially high-risk patients to become occlusal dysthesia patients and zero in on a particular bite, a tooth adjustment that you make, and they fixate on it, and this becomes an ongoing revolving door of them coming to the office to get adjusted, and 2 days later they're back in doing it again and again and again. At least that's my fear in managing these patients. And whether you're using a full arch orthotic or whether you are doing it on natural teeth, the risk for this particular group of people is very high. What is your opinion of that perspective?
Actually have dealt with, I take it you've had some experience with this, and probably had patients that had this. And so have I. I've had patients that have had this as well. So when we talk about concussions, we're talking about also, we're talking about things. Remember I said form a great team? I mean, having Sharon, that's that collaborative team where you can't do it all yourself. So a very important part of that, everybody that has a motor vehicle accident gets worse. They don't get better. I mean, nobody says, oh, look at that, a motor vehicle accident, now I can play the piano. That doesn't happen. They get worse. And so, but nobody is perfect. There's no perfect human beings in the world. So everybody gets a little bit worse on some of these biomechanical things. Now, a lot of the biomechanical things, if we deal with what happens in a motor vehicle accident, I just had a motor vehicle accident patient in today. She's having some pelvic floor issues. She goes, I don't do pelvic floor issues, but she has somebody that does that. She has the NUCA chiropractor that's very important to her. She still has a bit of strain, but that strain has got to do with some tendons and some muscles in regards around her coccyx. So those are mechanical things that with a great team that surrounds you, you can do that. Now, one of my team that surrounds me is a neuroscientist. So not a neurosurgeon. We do have in my team. We do have neurologists. They're great neurologists that we use, but a neuroscientist deals with brainwave patterns. And I'm sure Sharon's aware of this, that there's different brainwave patterns: alpha, high beta, low beta, theta, and what's the last one? Gamma. I'm having a senior moment. But anyway, these various different brainwave patterns can show up with concussion patients. And so you can use things like QEEG, which is basically they put this octopus on your head that's measuring your brainwave pattern, and use active biofeedback to get rid of feedback issues that are caused by a motor vehicle accident or by any other injury. It could be a hockey injury. I had a good friend that was when he was about in his early 20s, he was at a rodeo, and after the rodeo, they brought out a couch, as cowboys are apt to do in the rodeo. And they're all sitting around. He fell back off the couch and he hit his head on the dirt. You wouldn't think a big thing, but he went from a smart student to a student that couldn't pay attention and had problems. His life events kind of went downhill. He went and saw this buddy of mine, it's called Nirvana Health in Calgary, nirvanahealth.com. And they dealt with his brainwave pattern that had sort of sectioned this one part of the brain that was in this revolving function to calm it down and to get to a normal function. So that's something that we use for concussion patients. So concussion patients, there's a biomechanical and there's a neurologic aspect that you have to deal with. There's also a, when you're in a motor vehicle accident, you can get stretching of the occipital nerves. They come out of the nerve sheath and they get chronic pain, and that's where you're giving prolotherapy and things like that. So you're managing pain, you're managing neurology, you're managing head and neck alignment, you're managing the rest of the body down to their feet, and you're managing their occlusion. Just treating their occlusion alone is not going to give you stability. It's not going to give them the sense that they feel stable. And again, the second to last patient I had today, we're adjusting her orthotic using a TENS machine as she's standing up, just after she came from from NUCA, and I had seen her last week and she was perfect. She had a little bit more NUCA adjustment. She's even better with her alignment, but her bite was higher now on one side. We do those slight adjustments. Oh yeah, that feels really great. I feel even everywhere. And so it's a matter of knowing where to go, having the right people within that team that can help you. Back in 2002, I had NUCA. That was it. We've expanded that to there's about 15 docs that we send people to that know how to do certain things. And that makes a huge difference. So you can help those people, and that occlusal issue that they have may actually be something that they are going back and forth with due to some biomechanical instability. I see it a lot.
Okay, thank you very much, Lori, for the question, and thank you, Curtis, for the answer. We have another question in, and I'm going to ask both Dr. Morong and you, Curtis, to answer this. This is posed as an opinion, not looking for a science or a specific appliance, but the member says, can you prolong someone's life with a sleep or day appliance if they have heart failure and are on digoxin? Just looking for an opinion. Can you prolong someone's life with a sleep and or day appliance if they've had heart failure and are on digoxin? Who wants to take that one first?
Oh, I think the doctor needs to take that.
Okay, Sharon. See what happens when you show up? You get put on the spot. What are your thoughts, Sharon?
That's fine. So I guess that's twofold. One is, looking at sleep apnea, right, as the central theme here. The question with that patient was, did that patient have sleep apnea that was uncontrolled that made them at increased risk for the heart failure that they're presenting with? So if that was controlled earlier on, would they have been able to help prevent the heart failure? That is the whole premise behind us trying to diagnose patients who have sleep apnea and start to actively treat them, right? The second part of that is you have a patient who has heart failure now, right? Can you prolong their life? Well, from a sleep perspective, patients who have heart failure, they may have a tendency to have central sleep apnea, not just obstructive sleep apnea. So definitely in patients who have heart failure who are predisposed to central sleep apnea, treating the central sleep apnea could, we don't really have full evidence to say, yes, the mortality rate has decreased, but that is definitely why we treat these patients to help prolong their life, because the sleep apnea definitely does not help. So I would say heart failure patient definitely get tested, not only thinking about obstructive sleep apnea, but now that patient is at high risk for central sleep apnea as well.
Excellent. Thank you, Dr. Morong. Curtis, would you like to
About the only thing I can add is, I don't know if you dentists know who Bill Hang is, Dr. Bill Hang down in the States. And what Bill said is, if you live long enough, if you have sleep apnea and live long enough, you're going to die from it. So it's kind of blunt, but, deal with all of those issues that are going to create inflammation in the body. Sleep is obviously one of those big ones. Probably diet could be another one of those big ones. There's a whole bunch of things that can create a sympathetic response and increase the inflammatory load that may lead to something like a heart attack and cause problems.
Okay, thank you very much, sir. You deserve a good night's sleep yourself. So we'll let you go, and I'll say goodbye to everyone tonight. Thank you for your support. Don't forget to join if you haven't done so far. Tomorrow we go dark, but we'll see you for 3 more webinars in the month of June, and then hopefully come back with a revitalized program for the summer and fall. So thanks so much, folks. Thank you, Dr. Westersund, for coming.
Have a great night.
And we will. Thank you so much.